Let me ask a question first of Don. Why is UV not recommended in a HEPA air unit?
Well, UV is not a bug zapper. It's not instantaneous. And so the two ways that these are implemented in units, and I'm speaking generally, is in the airflow, which that is just a gimmick because the air is moving, at 30, 40, 50, 60 miles an hour through the air cleaner. And so it doesn't have time to be exposed to the UVC light long enough to kill it. The other way we see this implemented is over the surface of a filter, which in theory is a good idea, but in actual practice, it's just not that effective. But also, if you ask any manufacturer of HEPA material, the actual material that makes up a HEPA filter, if you touch it with your human hands, oftentimes it's no longer HEPA. It will not pass the same test it passed when it was manufactured. So now we take UVC, which is a harsh light, and put it on a filter. It's going to degrade the filter over time. That's our working theory, I guess, is what I should say. And frankly, if you can capture it, I think that's the best step. And then we've talked about other ways to deal with it. And I think UV light is a great solution. It's just not great in an air cleaner.
Great. And does anybody else have anything to say about that? Kim, you're muted.
I'll just add that I don't generally recommend UV in air cleaners that are HEPA air cleaners because it's just extra. And a lot of manufacturers add extra bells and whistles to charge more. And there's no need for it because the HEPA filter collects everything as long as the filter is seated right and is performing as expected. The UV is just an add-on that you're just going to pay for that you don't really need. Can I also answer the question that why haven't we seen more outbreaks in dental offices, which I have seen people ask me about. And I want to stress that there have been the reporting on outbreaks has been dismal. There has been literally no way that people have been investigating or reporting outbreaks as they should have. I mean, I can find reports of outbreaks in dental offices here in Colorado, and there are plenty, but they're just not recorded as they should be.
Yeah, I will add on to that because the way they do the contact tracing is they assume that if you are, more than 6 feet away, then they attribute that to you got it in the community. But you can, time will tell. And what I think, I agree with Shelly, like it's gonna come out. It's clear that, many of the workers in the dental care industry, they just randomly, catch it 3 times better than people in the community. There's a disconnect there, and it's going to come out in the numbers. So yeah, it's definitely a problem with the tracing.
And really quick, Kim, I see that I mispronounced your name. I didn't know it was Prather. I called you Prather. Sorry.
Yeah, no, I wanted to get it right by the end. It's good.
Yeah. There we go. Okay. There's a question here. People have stopped waiting 20 minutes in between their aerosol generating patients or people, and what your thoughts are on that. The wait time, that was essentially just, I think we were directed to wait 15 minutes between patients when they thought it was primarily droplet transmitted. But does that still have relevance if we're talking about a primarily aerosol transmissible disease?
Well, that relates back to my explanation of air changes per hour. If your facility is only at 3 air changes per hour, then waiting 15-20 minutes between the generation event will reduce the level of aerosol in your space. And so we generally recommend definitely allowing time for your ventilation system to clean the air. Now, if you supplement it with UV and your air changes are at 17, or you've supplemented with an air cleaner, so now your air changes are at 7, then the time between events can drop significantly to allow for the room to be cleaned appropriately.
Great. Okay, so we've all of you have suggested really important things. I'd like to just kind of recap and ask one question of each of you to state after all of this. What do you think is the most important step that we in dentistry, knowing how far behind we are, what should we do? What's the most important thing that all of us should do? If you could just pass a little, action steps to us.
I will start. I've thought about this a little bit. Again, I think there's just a gap between there's not that much known about how much is actually produced. And so let's avoid, the medical community just realize that AGPs don't generate much in terms of aerosols that they've been protecting against. So I would just encourage studies, where there's really straightforward ways to start to understand how much aerosols are actually being produced. So kind of understand, are you actually producing more? You may find out that there's not as much, and there's ways to do it, but to move beyond sort of the settling plates and thinking about bacteria, basically that would be adding maybe genomic sequencing and things like that to really understand what viruses are in the air. And this moves beyond COVID. This is would help health, for dental people for a lot further beyond, the flu and everything else that we've talked about. There is a good chance that all of these have had a huge airborne component that hasn't been acknowledged like it should. And so that last thing I'll say is just that's the key. Acknowledge it's airborne. Acknowledge that most of these are probably have a very big airborne component. It's not the only component, but it's probably the good likelihood it's the biggest component. One thing you have to also remember about aerosols, that once it's in the aerosols, the tinier they are, the deeper they go in your lungs. And so now they're starting to think that the disease can actually be much more severe than it would be if you got it off of the surface. And that's not something to take lightly. So acknowledge it's in the air, understand, sort of the sources, and then Shelly will probably want to comment on the best cleaning ways to clean it, because this is so fixable. But if you ignore it's in the air, we're just going to keep going down this route.
Thank you.
Yeah, I would recommend that you assess the state of your ventilation and what is your air look like. And I don't know, for hospitals, there's hospital standards for ventilation in buildings, and I don't know if that's the case for dentistry, but I would say if it's not, it needs to be done. And I would say starting with healthcare facility ventilation guidelines is a great way to start. But I think you need to invest in working with an industrial hygienist to come into your space and ask them, what does my ventilation system look like? How do I clean the air in my space? And then go from there in terms of supplementing and making sure your air changes and your ventilation rates per person are adequate to control infectious disease transmission, meeting the numbers that I have presented today, for example. Minimum of 6 air changes per hour and getting up to 10 meters per second per person in that space, at least by supplementing with UV filtration if your ventilation system is non-existent or is not providing you enough clean air.
Actually, can I just chime in really quick to tack onto that? Yeah. Good ventilation is not going to help you, though, as much for up close exposure when you have these really close contact. So you have to make sure that those people are properly protected. And so they should be wearing an N95 and a shield, right? And so make sure that the people that are the closest, because the best ventilation in the world isn't going to stop that up close inhalation. So I would be remiss if I didn't mention the respiratory protection.
No, that's exactly right. Ventilation, air cleaning, UV is for the long range transmission, but up close, I also really like Don's presentation where he emphasized source control, because as an environmental engineer, you start with the source and you try to control that immediately at where it's being emitted, because once it gets out into the environment, it's super hard to clean up, right? So you reduce it at the source, masks, PPE, source control, exhaust, whatever you need for the generation part. And then if you've succeeded, then you really don't have to worry quite as much about your general room air cleaning.
Yeah. And the suction does, as he mentioned, the suction does work. It looks like the one, I think I've seen 2 studies, it really drives down even the aerosols. So that's yeah, I agree.
Yeah, I like Don's approach of the layers. All of you have said this in different ways, that we're just layering one thing after another, both in time and space and distance, and we're just trying to put it all together in a meaningful way. Really quick, there is a question here asking you what your stance is on hypochlorous acid fogging.
Bad.
Like to hear what you say.
Don't do it. Don't do that.
No.
Do that. Don't do ionization. I see question 2, ionization. Don't do it. It makes actually toxic air. It makes other chemicals form that you don't want to breathe. So no, sorry, I jumped on that one, but that is just a way to make more money, and they're really taking advantage of people. Sorry, Shelly, that's your area. Shelly's shown this, and I just jumped in, but that question is a hot button.
Yeah, I mean, fogging in a space for chemicals that are lung irritants and oxidants like ozone and chlorinated compounds should never be done in an occupied space. And so that, maybe if you're needing to do a post cleaning because an infectious person came into your space, then you can treat that space, let it ventilate for 24 hours and then reoccupy the space. Regarding ionization, the technology has not been adequately vetted by the indoor air science and aerosol science and air chemistry science community. There is very little available in terms of substantial science. So at this time, we're not recommending them for this kind of application. Only things that have been vetted scientifically through engineering approaches, and is what we're recommending.
Okay, is there anything else any of you wanted to say before we close?
I would just say that, having some idea what it costs to outfit a dental office, in the implementing a lot of these things, especially when you compare it to the risk that you can be offsetting, does not have to be that costly. And just doing it stepwise right away, there are some things you can do right away that really improve this: the portable air cleaners, the chair side suction, just putting change. Unfortunately, it requires change, which everybody drags their feet on. But overall, the cost doesn't have to be prohibitive to get these things moving. And even in the long run, it's not. It shouldn't be a deterrent to making change here.
Thank you. All right, you guys, we're almost there. Thank you very much. Thanks for everybody who attended. We had one, let's see, I think there was one more question, but I can no longer see the chat, so I think we're finished with that. So we'll let everybody go. You can see the code. Thank you to my panel for sharing your wisdom from outside of dentistry to all of us. Sure appreciate it.
Thank you, Nancy.
Yes, thank you again to all of our speakers. The CE code is